Hi, everybody. I'm Reema Navalurkar. I am from New York, so I tend to talk fast, but I'll try to slow it down. I have been in Seattle training in internal medicine, followed by geriatrics, and I've recently joined faculty at Harborview Medical Center, which I'm very excited about. And I'm here with Marissa this morning to talk about frailty.
We have four objectives today. The first is to understand frailty as a clinical syndrome that increases vulnerability to a broad range of adverse health outcomes. Remembering that a clinical syndrome is a constellation of signs and symptoms that co occur and indicate an underlying physiologic process. We are going to learn to assess frailty by using standardized tools across the lifespan. As we all know, a 29-year-old who gets a UTI may recover with antibiotics, but a 90-year-old who gets a UTI might fall and get delirium and have other complications. So it's a much more complex assessment. We're going to implement frailty assessment to personalize comprehensive care and identify evidence-based interventions to address frailty. So meet Pauline. These are actually pictures of my grandmother. And you're her primary care provider. You have been seeing her over, so there are four cases. We're going to go through each of them over about 10-minute period. You can please work together. This was supposed to be workshop. We're in a lecture hall, but if you can kind of bunch up and get to know each other quickly, that would be great. Think about her functional status, her priorities, and how that will influence your treatment decision making. Okay? So imagine she walks into your primary care office and you're seeing her in these four different scenarios.
We'll give you about 5 minutes to chug some coffee and jot some thoughts down, and then we're going to come back together as a group.
I'll wait to advance.
Yeah, so.
Here, can we drop it for now?
I asked Liz about that, and she asked me to email her the document. It's also uploaded to the.
Maybe we should say something. So for those of you online, we believe that the document is uploaded and you should be able to access it to see the cases.
This is an awesome picture. I wish I had pictures of like that for my family.
Totally.
It's really cool.
Dad was a professor at Columbia chemistry, and so she grew up in like New Jersey.
On the water.
Yeah,
Cool.
Hudson Bay.
Cool.
Yeah. She went to Smith.
Is one of
Or no,
those,
she went to Mount Holyoke.
is one of those you?
No, those are my youngest brother and sister. There are four of us, and those are the twins.
Okay, I've been wondering that.
There were no children after that.
Okay.
Oh, cool. Okay, did you at least get a chance to read through them? Yeah, I'm seeing some head nods, maybe. Okay. So let's talk a little bit about frailty. So, as I said, it's a clinical syndrome. It's not a disease. It's not a disability. It's a complex, distinct, practical way to identify a complex physiologic state. It's predictive of many adverse outcomes: falls and fractures, hospitalizations, delirium, cognitive impairment, poor surgical outcomes, morbidity, mortality, and social isolation. Notice these arrows are bidirectional because we get into this vicious cycle, right? After hospitalization, after a poor surgical outcome, people get weak, they stop exercising as much, their appetite gets dysregulated, and then that kind of just sort of worsens the whole picture. And it's our job as clinicians to intervene. So, how is this useful? This is useful because frail patients, it helps us sort of identify folks who are going to offer stressful treatments or when they have acute illness to help them plan. It helps plan palliative care processes and lead goals of care discussions. For example, American College of Surgeons recommends frailty screening for all patients 65 and older. And it really enables us to tailor our care and personalize it to align with treatment of patient goals and life expectancy.
I'm sure if I polled this very awake room right now, I would hear lots of different characteristics that you associate with frailty. I mean, we all know it when we see it, right? There's been several attempts to make this a little bit less subjective and more academic and rigorous. This is really important to help predict those at risk for frailty so we can intervene beforehand. These are three commonly used ways to do that. I'm going to talk about the frailty phenotype, just described by the brilliant Linda Fried on the East Coast. This one has been around for about just over 20 years, and it uses biologic phenomena that we can measure objectively in a clinical setting. This has been revolutionary in the last 20 years because it has really sought to distinguish frailty from disability. It conceptualizes frailty as a biologic syndrome of decreased reserve and reduced resistance to stressors, resulting from additive declines across multiple domains. It uses weight loss, exhaustion, slowness, decreased activity level, and muscular weakness as these proxy measures. Whoopsie. It's important to see this as a continuum. If a person meets three or more of these five criteria, they are considered frail. If somebody meets one or two of these criteria, they fall into this gray zone or intermediate category that we call pre-frail. And this represents a state of increased vulnerability, but not, quote, full-blown frailty. And if you meet zero of these criteria, then you are considered robust or non-frail. Again, this has a strong predictive value as you move from robust to pre-frail to frail. It's associated with a stepwise graded increase in the risk of a variety of adverse outcomes that Marissa mentioned a few minutes ago, including falls, hospitalization, institutionalization, and mortality. Next is the Frailty Index. If you've been reading any of the papers that are coming out about frailty, I read somewhere that there's like 2,000 a year published on PubMed these days. You'll come across the Frailty Index. This is another objective measurement. It's based on this deficit accumulation model, which I'm sure you've seen in the literature. This suggests that the more health deficits one accumulates, the more frail you become. It's described as a fraction with the number of criteria that one has over the total number of assessed. So for example, if you're using a given tool that includes 40 possible deficits and a person has 10 of them, their frailty index is 0.25. In the literature, it's pretty rare to see anybody's frailty index exceed 0.7 because this is considered a biologic frailty limit beyond which survival is pretty unlikely. And again, this offers a graded approach. I will say that clinically, we don't use this one very much, but we very much use the clinical frailty scale, and I hope this looks familiar to everybody in the room.
Maybe AI will use the clinical frailty Not the clinical frailty scale, the clinical index, like within hospital systems using CMS data and using data to guide like surgeries and predictive models.
In practice, this one is very commonly used because it's easy. It uses activity level and dependence on others as a proxy for frailty. I know at Harborview, we're using this on the inpatient setting and in our clinic settings. It involves much less time. You can get this from your history. You can get this from talking to patients' family members, and somewhat of an eyeball test. I hope that font is big enough to see. I want to call out that an inherent limitation of this scale is its reliance on independence. I'm sure you can think of lots and lots of patients of yours who are unable to live on their own because of a physical disability or maybe social factors, but are not considered frail.
So as discussed, frailty is a multidimensional biologic process. Um, it is related to age. We have cellular senescence, neurodegeneration, sarcopenia. It's also related to social determinants of health, genes, environment, and the problem list. And the cumulative sort of, this is more of the cumulative deficit model. The longer the problem list, the more, cardiac disease, CHF predicts 5-year mortality, that sort of thing. You can think about it that way. That alters energy metabolism, stress response impairment, creates sort of this cycle of chronic inflammation, autonomic dysfunction, neuromuscular decline, leading to physical frailty, which then leads to the geriatric syndromes and disability and ultimately mortality.
I hope that shows how the various models we talked about kind of all tie together and have a biological basis describing our syndrome. Because we tend to accumulate problems like this and our cells naturally degrade over time, we consider frailty a age-related phenomena. We are more likely to get frail as we get older. In a report covering 62 countries worldwide, the prevalence of frailty among people living in the community from 50 to 59 was about 11%, and then stretched over 50% for those living 90 or older. This is why our job is so fun. Aging is inevitable, but it's hugely, hugely variable. Frailty assessments are so critical in personalizing care plans for our patients. I'm sure you can think of two 75-year-olds from similar backgrounds who are aging vastly differently and would have different levels of reserve if faced with a stressor.
So this is the graph that kind of made me go into geriatrics. You can see that function is on the y-axis and age is on the x-axis. And there are these red arrows pointing upward. Those are stressors. Up top, when we're young and fit, we are in a state of high physical resilience. What is resilience? So there's this very beautiful JAGS article that describes resilience as sort of like the San Francisco Golden Gate Bridge. And if you imagine that the pillars of that bridge, that's sort of the frailty, the clinical frailty scale. So the pillars, if you take those pillars away, we lose our ability to respond to stress. And then the cumulative deficit model, if you take the cords or the suspension cables away one at a time, we lose our ability to respond. And resilience is the bridge's ability to respond to wind, water, and traffic. And if those start to fall and fail, they're not going to be able to respond. For an older adult, that's similar, right? We can imagine that as we lose our reserves, we can't respond to hospitalizations, a fall, an infection. Healthy aging, we still have this slight sloping decline, and there are moments where we have a stressor and we can bounce back with rehabilitation, PT, OT, the right meds, not too many meds. But we all die and we all reach a vulnerable state at some point. And so what our jobs are as clinicians are to build folks back up and really promote the the factors of resilience and strength that allow us to handle stressors. You can see that even late in life, it's possible to build back reserves. And I think that's important to remember. And for Medicare to pay for more rehab and for rehab to be more intense in the hospital and all of that. Okay, so comprehensive geriatric assessment. Many of you are probably familiar with this. It's time consuming, it's interdisciplinary, it assesses multiple domains, including activities of daily living, mobility, cognition, vision, hearing, continence, nutrition, mood, polypharmacy, social history, advanced care planning. The Medicare wellness visit is supposed to address some of these things and use an evidence-based approach to it. It has not shown in primary care to be different than usual care. That is yet to be proven. And so I think researchers in the 90s and early 2000s realized that, and they said, who should we focus these interventions on, right? And they noted that there needed to be something that described this, and that is frailty, right? And if we focus a more intensive intervention on those who are frail, perhaps it will be useful. And it has been shown to be useful for surgical and oncologic planning. What is a very quick way to do this in a 20-minute visit if you have to? Just asking. There are thousands of frail sort of screenings, right? You can find thousands, but incorporating, are you fatigued? Do you have difficulty walking up one flight of stairs? Do you have difficulty walking one city block? And then looking at their problem list. Do you have more than 5 illnesses and health conditions? And have you lost 5% of your body weight in the past 6 months? That weight loss pattern is actually like sort of more of an end stage part of being frail.
Just going to go back one slide to point one thing out. If this looks remarkably familiar, it's because it's based on the Freed scale that we talked about a few minutes ago. And this is something that a lot of clinics are handing out to their patients. And again, I want to highlight that once somebody becomes frail, when they lose this reserve, it's fairly easy for us to see it, at least when it's too late, when you're watching somebody in the hospital decline or face a fracture and have a difficult time rehabbing afterward. And our job as clinicians is to really catch this pre-frail category so that we can intervene early. And when we've noticed that somebody is really properly frail, to adjust our subsequent care accordingly. The ways that we do in our clinic on a daily basis to assess people who are at risk for frailty and are frail include the 30-second sit to stand test. I love this test, A, because it brings out the competitive spirit in a lot of my patients that I adore. B, it literally takes 30 seconds. And C, we know that this is a very useful test. This is a maneuver that people are doing at home that allows us to kind of see how they're navigating their home environment. It's strongly associated with frailty. This test is probably impossible for our quite frail patients. It takes a lot of coordination and strength of your core and lower extremities to stand from a chair without using any help and to continuously do that for 30 seconds. But it provides, again, helpful information for those who are pre-frail or at risk. Lower performance on the 30-second sit-to-stand test is consistently linked to higher frailty risk and worse functional outcomes. We were initially going to ask you to do this, but I've decided since it's not yet 8, I'll spare you. Another thing that is part of the Medicare annual wellness visit and that senior care at Harborview is very lucky to have a roped off area to do this. And I hope that more clinics follow that model is the timed up and go or the tug. This again asks patients to rise from a chair without using their arms, walk a set 3 meters, usually marked by a piece of tape or a cone, or the provider sometimes, and return back to their chair and sit down. You are armed with your smartwatch or a phone or a stopwatch, and you are timing how long it takes them to do this. This is a validated performance-based test that serves as a functional indicator of gait speed and balance, and again, lower extremity strength. All of these domains, I hope you are convinced, are related closely to physical frailty. Slower performance correlates strongly with higher risk of falls, functional dependence, hospitalization, mortality. And again, this gives us an opportunity to see how people are navigating their natural environment. Once you have a score, this helps us tailor what kinds of interventions to recommend. If somebody is taking longer than 30 seconds to do that, that is quite a long time to walk 3 meters. They are probably not appropriate for independent community programs. If someone is in this moderate risk category of 20 to 29, I strongly recommend dedicated supervised physical therapy, but there are some candidates who might consider a community program. And if you're taking less than 19 seconds to do this, then you can continue to recommend independent exercise, Tai Chi, physical therapy. I love physical therapy. I could not stand up here and tell you about factors related to frailty without commenting on social determinants of health like income, education, social support, neighborhood, access to care, all of which shape how we age in measurable and immeasurable ways. Lifelong advantages or disadvantages like systemic racism and disparities influence our physical function, mental health, and independence in later life. At Harborview, we certainly see this on a daily basis.
So this graph is from a New England Journal article that came out last year. And it very eloquently is a nice table to sort of divide how we focus our interventions. So the green over here is fit, then pre-frail, frail, and end-stage frailty. Okay. Talking about the clinical frailty scale. So you have your fit person. What are we going to recommend? We're going to recommend to increase their physiological reserve and pre-frail as well. That's what we're doing. By the time we progress to 5 or 7 deficits, that's when we stop being able to bounce back as easily. And that changes our goals to preserving physiological reserve and to prevent avoidable stressors. So in these folks, for example, fall prevention is going to be incredibly important, delirium prevention, et cetera. And then at end stage frailty, we're going to provide comfort and change our goals to be palliative. What are we recommending? So as you all know, exercise is kind of divided up into endurance training, balance, and strength, right? And so for community dwelling adults, I use the 150 minutes a week, divided any way you like, moderate exercise. And then I encourage weightlifting or some sort of resistance exercise at least twice a week, ideally 3 times, and incorporating balance into that with Tai Chi or yoga. In hospitalized patients, and I haven't worked in a hospital in a while, but the recommendation is resistance training with 20 to 90 minutes per session, 2 to 5 sessions per week. Tai Chi and yoga improve muscle strength and balance, so they are very helpful. For our fit folks, we want to apply disease-based guidelines. As we progress into frailty, we start to weigh the balances and trade-off between the disease and treatment burden. And then at end stage frailty, that's when we start to de-escalate our treatments. We are always going to recommend vaccinations. We are screening for cancer in our fit and pre-frail individuals. And once we reach a state of frailty, we start thinking about things like time to benefit and remaining life expectancy and patient-led goals, right? And then we start de-escalating those treatments at end-stage frailty. We start, one more thing, sorry, comprehensive geriatric assessment. We don't need it in our fit folks. We start to use it in our pre-frail individuals, right? And we pull in more team members, PT, OT, speech, et cetera, to help us with that. Pharmacy, can't forget that, and they're amazing.
I wanted to plug an incredible resource that's free and available online from UCSF that I use all the time. I hope that this is something that you've heard of before, but on the off chance you haven't, this is great. It's ePrognosis at ucsf.edu. This is a way for us to visualize and calculate, again, evidence-based ways to weigh somebody's life expectancy against the time to benefit for a given intervention. Time to benefit meaning if you do this test today, how long will pass before you actually see some benefit of the intervention. I have a screenshot of the cancer screening portion of the slide, but I promise you it's more comprehensive than that. When you go to this website, it'll ask you for information, including frailty indicators and other comorbid conditions, and then some demographic information to calculate life expectancy. It asks you for information about whether this person is community dwelling or living in a SNF or hasn't been able to leave the hospital. And then that information is used to guide life expectancy. It gives you a range, which then you can plug into this time to benefit calculator. And you can slide this orange bar left and right to see what kinds of things are evidence based to recommend and what kinds of things is probably not in our priority list right now. When we're talking about interventions for frailty, I think this is the meat of what geriatricians do and what I hope to inspire you to do. I've given talks on frailty quite a lot in the last couple of years, and the feedback I've gotten again and again is like, yes, I get that this is important, but I don't know what to do with it now. And so I hope that this will be helpful. As Dr. Black mentioned, we do a comprehensive geriatric assessment in the folks that we deem at risk for frailty and indeed frail. The Geriatric Comprehensive Assessment, or CGA, is a multidimensional evaluation. As you mentioned, we're using all of our team members at our disposal. They are so critical. We are looking to see what their medical, functional, physical, psychological, and socio-environmental status is to develop a coordinated plan to protect them at home. So this is making sure that you are targeting things that we know increase somebody's frailty and that are reversible. So making sure people have annual eye exams, making sure their hearing is optimized, making sure that we're working on their balance to decrease the risk of falls, and then treating reversible conditions as much as we can. And as Dr. Black mentioned, that we haven't shown that this is broadly applicable in the literature quite yet, but we know that in the right population, these people that are at risk for frailty and are indeed frail, that this reduces unplanned hospitalizations in older adults, it reduces in-hospital delirium, in-hospital falls, and length of stay. I'm going to go back to this chart for a second that, again, we love. And if you're visual like I am, I thought it would be helpful to plot these categories onto our chart. We see that fit people are doing pretty well. I don't really worry about them as a geriatrician, except, of course, to preserve those things that are making them fit. The people who are pre-frail are starting to face some stressors and are just able to compensate for those stressors, but you might see very subtly that they're not quite bouncing back to their previous baseline. And then once you're frail, you're having a hard time. I like Dr. Fried's description of frailty as you have exceeded your ability to compensate for the stressor. Your resilience is not keeping up. And then end stage frailty is really the point where we're de-escalating interventions where we know they're not going to bounce back well, and we are focusing on quality of life and comfort. I hope this is not new to anybody in this room. This makes me smile every time I see it. Age-friendly health systems is a movement across medicine to make geriatric care and indeed care for all older adults more in line with what matters to them, and everything we do is in service of that. And we are looking at the 4 M's: the way they navigate the environment or mobility, the way they think and the way they feel or mentation, and what medications we are throwing at them. And I'm hoping that this workshop has given you some tools to consider how to apply a frailty lens through the 4 M's for our patients. So I'd like to go back to Pauline's case now on the worksheet we handed out a little bit ago. And I wonder if there's anything that you're reflecting on or that you would do differently, whether you got slam dunked the first time around.
So how would we deal with case one? So Pauline is a independent 65-year-old woman with an active lifestyle. She enjoys hiking, skiing, traveling, playing piano. She has early erosive osteoarthritis. She smokes cigarettes, consumes alcohol during social events. She lives with her husband and cares for her 9-year-old mother. When Pauline was sick with pneumonia last year, she developed delirium and situational depression. How would you describe her functional status?
Pretty fit.
Pretty fit, yeah. What do you prioritize during her clinical visits? Yeah, so what would you recommend? Quit smoking, yeah. Minimize alcohol. And so, yeah, at this stage, our focus is healthy living, healthy lifestyle, maintaining those social connections. Okay, case two.
Really quick.
Yeah.
I like the way that this case is written because it shows that she's developed delirium. She had a situational depression occur during this hospitalization. So it's not to say that fit people don't experience age-related syndromes or things that we associate with, well, I guess it's an age-related syndrome, so I'll skip that thought. But she's able to bounce back, which is the critical part. Okay.
So at age 75, she moves to Washington after the death of her husband. She quit smoking on your advice. Her primary care provider, you, has been managing her hypertension and diabetes very well, and she has very few medications. She did have to stop hiking and playing piano because of her osteoarthritis and early macular degeneration. Now she's pre-frail, right? And what would you prioritize at this point?
I didn't plan this. I wrote these cases ages ago, but I met a man very similar to this yesterday whose entire social network was his hiking group, and now he's no longer able to hike and now quite socially isolated. So we spent our visit looking up ways for him to be physically active and meet people that are maybe a little bit less physically challenging, but still get his heart rate up and get some physical activity in.
And thinking about what macular degeneration might put her at risk at, right? Because we don't want her to fracture her hip. And we also want to make sure her pain is well controlled for her osteoarthritis so she can continue to be as physically active as we hope her to be. Okay, Pauline's now 85 years old. You are aging with her. She has hypertension, diabetes, uterine prolapse, osteoporosis, and osteoarthritis. She went for an elective right hip repair at your recommendation at age 83, which vastly improved her function. But then, a few years later, she fell at home and suffered a fracture of her left shoulder, and she needed a shoulder replacement. She spent a few weeks at rehab, and she was able to return home to her house. What are you thinking about now?
Now it's a little bit more complicated. She's starting to accumulate some chronic conditions that are putting her at risk for multimorbidity, polypharmacy. She's undergoing some surgeries that are taking a little bit more effort to bounce back from, but she's doing it. And so I think she's now on the borderline of pre-frail and frail. And this is when we're really spending time talking to her about what's important to her. If she wants to continue living at home, how do we preserve her independence? What kind of stopgapes do we need? How can we keep her safe and functional at home?
She declined surgery for her uterine prolapse. You treat her osteoporosis, which, as primary care physicians, you can all do, and you keep her off meds that might make her prone to delirium. Okay, now, Pauline is 93. She's legally blind from her macular degeneration. She takes several medications to manage her hypertension, diabetes, COPD, osteoarthritis, AFib, osteoporosis, and she presents to you with dyspnea and worsening depression. You astutely diagnose severe aortic stenosis and recommend a TAVR, but only after you elucidate her goal to remain home and attend her granddaughter's graduation the following summer. She's frail at this point, right? Post TAVR, she feels well and continues to live alone with a part-time caregiver. Her daughter and granddaughter live nearby and check on her daily, but they tell you she seems to be more easily fatigued and forgetful. I'm going to stop here for a second. So I have, recommending TAVR can, I've had people come into my office with a TAVR and they're doing really well afterwards, but they sort of wish on occasion that they didn't do it. Not necessarily that I had recommended it to them, but that they're still alive, you know? And then they just accumulate all these deficits and they say, what am I living for, doc? So I think the important thing or lesson that I've learned from that is that they really have to feel like they have purpose, right? we can extend people's lives, right? We can keep doing all the things, but identifying what matters to that person, what brings them joy, vitality, purpose, treating their mood and mentation, right, is so important. Okay. So at this point, she's 95. She's staying at an assisted living facility for respite. While her daughter's out of town, staff provide her medications, assist with transfer in and out of bed, help her get dressed each day. And she's noted to be confused, especially in the evenings. And the staff call you because they worry about her living alone. So how do you handle this now? I feel like I'm talking to a room of very seasoned clinicians, so I know you know how to do this. Yeah. And you figure out what she wants, right? Does she want to go home? Does she want assisted living? What's her family capable of doing? What's her social support system? I think like at this phase, that's the most important thing. And then caring for the caregiver. So making sure that we are specifically addressing the caregiver's needs and stressors because this is hard, right? Like aging parents, it's a huge stressor on families as well. Other thoughts?
You nailed it. Should ask the audience. Any thoughts in the audience?
The other thought, more confusion is, that a change where you're looking at it is always gonna be hard.
For sure.
Now, will she do better when she goes back to?
Right. I think it's so personalized, right? Some people, they are social beings to their core, and those folks tend to do well if they move to the right assisted living, where they have a friend or the right activities, or the right adult family home with that caregiver who has a cat and little kids and other folks, they're just going to stay at home and we just do what we can to support them. And it can be really tricky to watch folks decline without the supports that they need. But sometimes it's the right thing in some ways to respect that autonomy of that older adult. Okay.
Your point is well taken.
Your
that
point.
we have introduced a stressor to her life.
Yeah. Because sometimes people do fail after they move, right? Yeah, especially like the family, the kids move the parent across the country and they end up in a place that's not the right one, and it can be really tricky. Yeah, I'm sure you're all familiar with that scenario.
I'm actively trying to move my parents to this coast. Yes.
He's really helped really know that balance dynamic. Because well carrier for that and I said something. So last year money you're talking about that she's around she's just going down the balance that we can take care of her. Sure us. She lived like 3-4 years.
Wow.
So it's like how to take care of.
Totally. And if you find the right adult family home, like King County alone has 900 adult family homes or something like that. So if you find the right one, it can be life-changing for some of these frail older adults. And it's a really awesome model that we have in Washington State. So, questions?
Or other thoughts?
Yeah.
Well, thank you for being so engaged early this morning. We are around if you have any other thoughts or questions or feedback for us, we would warmly welcome. Thank you.